Hello, I'm Professor Emily Mercuri, and this is Chapter 9, Administration by Parenteral and Other Routes in Essentials of Pharmacology for Health Professions, 9th edition. Chapter Objectives. Upon completion of this chapter, the learner should be able to name 4 administration routes with systemic effects, explain administration via the sublingual and buccal routes, including instructions to the patient, demonstrate application of transcutaneous medications, compare and contrast the advantages and disadvantages of the inhalation route, describe patient education for those receiving inhalation therapy with handheld nebulizers, contrast small volume nebulizers, metered dose inhalers, and dry powder inhalers, identify the parts of a syringe and needle, and select appropriate length and correct gauge needles for various types of injections. List the 3 types of syringes and their purposes. Demonstrate drawing up medications from a vial and an ampule. Describe an intradermal injection. Describe a subcutaneous injection. Describe 3 sites for intramuscular injection. Describe intramuscular injection. Give the purpose and a demonstration of Z-track injection. Discuss IV administration and various types of IV fluids that can be prescribed. Identify 3 local routes of administration. So parenteral routes include any route other than the oral route. Parenteral is defined as any means of injection that bypasses the skin and mucous membranes. Other routes that must be considered besides injectables are the skin, which is considered the transdermal route, mucous membranes, sublingual and buccal routes, eyes and ears, otic and optic routes, and respiratory tract, inhalation route. The chosen route of administration can be better understood if the purpose of administration or the desired effects are considered within 2 categories, systemic and local. So remember that systemic, think of the word system. Systemic effects are across the entire body, and the goal is distributing the medication through the circulatory system, or the bloodstream, to the area requiring treatment. So routes that will take systemic effect that will end up circulating through the bloodstream are the sublingual or buccal route, the transcutaneous or transdermal route, inhalation, and injection. Local effects, on the other hand, think about like when people say, go to your local restaurant, right? It's in your area. So local effects are staying in one area. They're limited to one part or location with very little, if any, effect on the rest of the body. Medications within this category include topical medications that are applied to the skin for skin conditions, drugs that are applied to the mucous membranes to treat specific tissue, so they're targeted drugs, medications that are instilled in the eyes for eye conditions, and medications that are instilled in the ear for ear conditions. Knowledge check. Which is not considered a systemic effect route? A. Transcutaneous, B. Inhalation, C. Transdermal, D. Injection. And the answer is C. Transdermal. Sublingual and buccal administration. So sublingual, the words literally mean sub, under, lingua means tongue. So this medication is placed under the tongue. The sublingual route is more common than the buccal route, and this medication is absorbed directly into the circulatory system or the bloodstream. Administration instructions. When you're giving a sublingual medication to a patient, they need to know to hold the tablet or film in place with mouth closed until it is absorbed. I say film because some medications come in this thin kind of, it looks almost like a tiny piece of paper or even like a transparent little piece of plastic, and it's actually a medication that dissolves, or it is in a tablet form. So they need to hold that in place with their mouth closed until it's absorbed. You place it under the tongue, they place their tongue on top of the medication, and then they close their mouth. Do not swallow the medication because, again, it's meant to be absorbed in this manner. Swallowing it can alter the absorption. And then do not eat or drink for 15 minutes until the medication is absorbed. We don't want to wash any of that away or wash it down the esophagus. Some medications that are sublingual, including like allergy pills. I have a pill and it's a microdose exposure to dust mites. And so I take it every day so that my body builds up a tolerance for dust mites. If I swallow it, it's a sublingual, and if I swallow it, my throat gets really itchy because I'm exposing my throat to that allergen where it's meant to just be absorbed under the tongue and then through the bloodstream. And so that's one reason, one example of why we wouldn't want to swallow certain medications. And again, the absorption is going to be different if you swallow it. Buccal administration. The medication is in a pouch and it's placed between the cheek and the gum at the back of the mouth. This medication is unaffected by the stomach, intestines, or liver, and it's a very rapid route of absorption. This method is used when quick response is required and it provides quick relief. So in this case, they need to hold the tablet or film in place with the mouth closed until it's absorbed, and do not swallow the medication. Do not eat or drink for 15 minutes until the medication is absorbed. You can imagine this one is a little bit harder to administer because once you have something in your cheek and you close your mouth, the temptation is going to be that saliva is going to build up, and that's just a natural response your body will have, and you're going to want to swallow that. And you can swallow, but usually we wait at least 30 seconds to a minute to even swallow saliva because we don't want to swallow any of the medication. Whereas under the tongue, it's a little easier to keep your tongue over the medication and make sure you're not swallowing any of it. So buccal is a little bit trickier for patients. Knowledge check. When administering medication sublingually or in the buccal route, patients should not eat or drink within blank minutes. A, 5, B, 10, C, 15, D, 20. And the answer is C, 15. Transcutaneous drug delivery system. Transcutaneous and transdermal systems both deliver medications to the body by absorption through the skin. Transcutaneous delivery systems utilize a patch impregnated with a particular medication. This is applied to the skin and left in place for continual absorption. Absorption by the transcutaneous method is slower, but the action is prolonged than with other methods of administration, meaning it's absorbing at a slower rate and it's happening over a longer period of time, meaning that the action is actually going to also be prolonged, so the drug will last longer within the body. The intended effect of the drug. The drug is released at a constant rate so that the concentration of the drug is kept at a certain level in the body, so we're not overdosing on the medication or getting too much of it too quickly. Transdermal administration instructions. There's an image here on this slide that demonstrates proper transdermal administration of nitroglycerin. It's important to remove the previous patch carefully and discard appropriately. So if you're ever giving a medication via this route, you need to check the body and make sure that there is no previous patch or area of the body that still has medication on it. The patient would then select a site for the new administration, remembering to rotate areas. And when we say this, the patient does have a say in where they would like it, but depending on the type of patch, there are areas that are going to absorb better. So it's not just a free-for-all, like you can put it anywhere on your body. For instance, with nitro, we do typically put it on the upper chest or upper back, and so we can give patients a few options, but not, it's not going to be on their leg, for example. It's important to make sure that the skin is clean, dry, and free of irritation. So if you see any kind of open skin, any kind of rash, redness, we're going to avoid that area. The patient opens the packet if they're putting it on themselves, or the healthcare professional will open the packet. Pull the two sides apart without touching the inside. It's then applied by placing the side containing the medication to the skin and pressing the adhesive edges down firmly all around the patch. So for nitro, there's different forms, but the one that they're showing in this picture, it is a paste that you are actually placing onto the patch yourself, and there's a little measurement tool on the patch. And then you make sure that the patch goes flush with the skin, that it's pressed down on all sides, and then make sure that the hands are washed after the medication is applied. Certain patches must be removed prior to non-invasive procedures, such as cardioversions or defibrillation. Also, if we're giving a patch medication, we don't want to get that on our fingers especially if you're the healthcare worker giving it to the patient and you are not the one getting the medication, because, for example, this nitroglycerin, the goal of it is to open up the blood vessels to allow blood flow through the heart. It's given for when people are having some reduced blood flow in their heart or lungs. And so if somebody like me or you who has a normal blood pressure, right, touches this medication, that could drop my blood pressure and cause issues for me. And so we don't want to accidentally absorb any of the medication that we are placing on the patient. Knowledge check. When applying a transdermal patch, the patient should A. Place the patch over the existing patch. B. Push the sides together to disperse the medication equally. C. Throw the old patch away in the garbage can. D. Rotate placement locations. And the answer is D. Rotate placement locations. On the note of the answer that said throw it in the garbage can, we should be disposing of it in an appropriate medication waste bin. And if it's being used for home use, there are waste bins that patients can get that they can then bring back to facilities, such as like the pharmacy, or sometimes they instruct the patient to wrap it in a used glove, make sure that it's knotted, make sure that it is not something that could ever be, someone could go through the trash and accidentally touch it, because again, we don't want this medication to affect anybody other than who it's intended to affect. Inhalation route. Medications are frequently administered through inhalation, especially to those with chronic pulmonary conditions. If you're not familiar, pulmonary refers to the lungs, so conditions of the lungs. There are various ways patients may self-administer inhaled medications, such as a metered dose inhaler, dry powder inhaler, or small volume nebulizer. So for a metered dose inhaler, when the patient pumps the medication through the chamber, it will deliver a measured amount of that medication, and usually it will have a number on the top. So let's say they start with 50 doses of the medication. When they press the chamber, take their first dose, it will then say 49. So you can tell that it is counting down the number of doses left in the chamber. And then for dry powder inhalers, when the chamber is squeezed, the powder within the inhaler will activate to become nebulized or aerosolized so that the patient can inhale it. And then a small volume nebulizer is a little bit different. It's usually hooked up to a small chamber that has liquid in it that will then nebulize and that the patient can breathe in. Oftentimes that is more done in the hospital, but you can get nebulizers for home use as well. Advantages of the inhalation route: it is a rapid acting medication, it's convenient, and it's comfortable for patients. And there are minimized side effects due to smaller doses based on potency. Disadvantages of this route include improper administration, especially for our younger patients or our elderly patients who have a hard time pulling in the medication. So essentially you inhale, you kind of suck the medication in and you hold it and it goes down into the lungs. If you can't take a slow breath and draw in slowly and then kind of hold that, it's going to not be as activated. It's not being administered properly or thoroughly. Other disadvantages: dependency for patients with asthma or COPD. So patients do become dependent on these medications, especially certain like steroid inhalers can cause a dependency effect. A source of infection if not properly cleaned, because the inhaler itself can get bacteria on the surface. And then adverse symptomatic side effects due to the extensive absorption capacity of the lungs. So while the intention of this medication is to affect the lungs, because lungs have such absorbent tissue, it can also cause a systemic effect. Knowledge check. The advantages of the inhalation route include all of the following except A. Extensive drug absorption in the lungs. B. Smaller dose size. C. Convenience for patient. D. Rapid action. And the answer is A. Extensive drug absorption in the lungs, because remember that is a disadvantage. Small volume nebulizers are utilized to deliver various medications in aerosol form to the patients. A nebulizer is powered by a gas source and a small air compressor in the home setting. Proper breathing techniques must be used for optimal drug deposition in the lungs. In addition, it's imperative that proper cleaning be conducted of the nebulizer to ensure the safety and health of the patient. So, if you are administering a nebulizer, to ensure proper administration, the patient should be instructed to inhale slowly and deeply, perform a short breath hold, and exhale slowly. Side effects may include dizziness if they hyperventilate. So if they are breathing in and out too rapidly, it can cause dizziness. Knowledge check. Which instruction is not included when providing guidance to patients on how to administer nebulizer treatments? A. Exhale rapidly. B. Perform a short breath hold. C. Inhale slowly. D. Exhale slowly. And the answer is A. Exhale rapidly. Remember, we need to instruct to both inhale and exhale slowly. Metered dose inhalers, as I mentioned earlier, they deliver a measured dose via a propellant within a canister. These devices are portable and easy to use. However, proper administration by the patient is essential for drug effectiveness. If needed, you can add a spacer to act as the reservoir for the aerosol, allowing the patient to first depress the canister and then inhale. There is a spacer pictured in the image below. So on the right-hand side, you see the inhaler itself, and then it goes into this kind of chamber. And then on the other side is an opening for the patient to slowly inhale the medication. There are safety measures on many spacers that provide a horn or whistle, which signifies the patient is breathing too rapidly. And then that spacer kind of holds the medication. So if they need to take a few more slow breaths versus getting the medication delivered in one pump, the spacer is really helpful. It's especially good for children. Just speaking from personal experience, I do have asthma and I use an inhaler. And one of my children unfortunately inherited the asthma. And so when he started taking an inhaler, there was no way he was able to take one without a spacer because he was just too little to take that big inhalation and hold it. And so the spacer helps to deliver the medication in a little bit more of a fashion where the patient can take a few extra breaths and that reservoir kind of holds it in place. So this is a really great option for both young children and the elderly or anyone who might have a hard time with the process of just using the normal inhaler. Dry powder inhalers are devices that deliver a drug in powder form into the lungs with no propellant or external power source. The patient must generate a sufficient inspiratory flow rate for the powder to aerosolize properly. Therefore, dry powder inhalers are used for prophylactic treatment and not for acute breathing problems. Which makes sense, right? The patient needs to be able to take a deep inspiration for the powder to aerosolize. It's not going to work if they are breathing shallowly or rapidly because they're in acute respiratory distress. Advantages of the powder inhaler: small and easy to carry. Estimate timing of inspiration technique. Disadvantages include fewer drugs are available in this dry powder form, and they do generate a significant inspiratory effort for the drug to be properly delivered, meaning there's a lot of user error. If it's not taken correctly, the drug is not going to work correctly. Knowledge check. The device used to act as a reservoir for the aerosol, which allows patients to first depress the canister and then inhale, is called A. Nebulizer, B. Metered dose inhaler, C. Dry powder inhaler, D. Spacer. The answer is D. Spacer. Parts of syringes and needles. So when we are talking about injectable medication, to administer injections, it's important to be familiar with syringes and needles. Most syringes are plastic and are disposed after each use. Some syringes utilized in procedures may be glass, and in that case, they are sterilized after use. The parts of the syringe. So there's an image here below. I recommend you taking a look at the image. Barrel is the hollow cylinder that holds the medication. It contains the calibrations for measuring the quantity of medication. It's important to note that this part is not sterile. You see on the image here that there are little dashes indicating the number measurement. It depends on the size syringe you have, but oftentimes it will be each dash is 0.25. But again, it depends because there are some barrels that are for a very small amount of medication where each dash is a tiny number. But oftentimes you will see that it's the whole numbers are marked and then the little dashes in between are going to be parts of the number. Plunger is the inner solid rod that fits snugly into the cylinder. Pulling back on the plunger allows the solution to be drawn into the syringe. Pushing forward on the plunger ejects solution or air from the syringe. The inner portion of the plunger is sterile. So once you open the package, all that this is saying is that the barrel itself is not sterile because it's open out to the air, but the plunger part of the syringe, because it's still internal, it's in the inside, more sterile part of the barrel, it's considered sterile. The tip is the portion that holds the needle. Most tips have a system called lure lock, which locks a needle in place. The tip is sterile, so you don't want to be touching that or contaminating that. A lure lock means that a syringe can be screwed into a IV or a IV tubing if the medication's being pushed into like a longer tubing that's attached to a bag. It used to be that you had to use a needle to access the system, but they created this lure lock, which is kind of this little locking part that just screws into the other piece, which is really helpful and helps eliminate the opportunity for needle stick injuries. Needles themselves have 3 parts. The hub is the flared end that fits on the tip of the syringe. This part is sterile, meaning you should not be touching the end of this or the end of the syringe. You should just be pushing the 2 parts together and screwing that lure lock on. The shaft is the long hollow tube embedded in the hub. Needles have shafts with different lengths. Various sizes for shorter needles include 1/2 inch, 3/8 inch, and 5/8 inch. So that has to do with the actual length of the shaft. These are used for intradermal or subcutaneous injections. The gauge is the size of the lumen or hole through the needle or the diameter of the shaft. The gauge is numbered in reverse order, meaning the higher the number, the smaller the lumen. I will attach an image onto your canvas showing some various different gauges, but what that means is, for instance, an 18 gauge or a 20 gauge needle, that's what we usually do for IVs. An 18 gauge is bigger than a 20 gauge. A 20 gauge is bigger than a 22 gauge. And so it's in kind of reverse order, which is confusing, but again, I'll attach an image. Something like a 24 gauge is going to be a really tiny needle that we might use to inject a bit of lidocaine when we're numbing for a wound, something like that. Whereas an 18 gauge is a much larger needle. I would use that if I have to give a patient fluids really quickly or if they need a blood transfusion. And so the smaller number corresponds to a bigger needle size in terms of the actual kind of width of the needle. But again, I think the images will help, so I'll go ahead and attach those on Canvas. The size of the gauge is determined by the site of injection and the viscosity of the solution. So what that is saying is not only is the gauge size, does it change based on need, but it also changes depending on where the injection is going on the body itself, and viscosity, meaning how viscous is the solution. Viscous, think of like Jello versus ice cream versus water, right? So Jello is like more thick, more viscous. Ice cream, it can melt a little bit. It's a little bit less viscous. Water is not very viscous. If you're not familiar with that term. So if something is viscous, more viscous, is a little bit thicker, you're going to need a larger needle gauge. The shaft of the needle is also sterile. And then the tip of the needle is the pointed end, and it has a beveled edge. And you can kind of see it on the image, but a beveled edge means it's kind of at a diagonal. The tip itself is also sterile. Knowledge check. Which part of the syringe is not sterile? A, tip, B, barrel, C, plunger, D, hub. And the answer is B, barrel. There are 3 different types of syringes generally used for injections. The standard syringe is most frequently used for subcutaneous or intramuscular injections. Remember, subcutaneous means under the skin or intramuscular into the muscle. It is calibrated or marked in cubic centimeters or milliliters. The most common size used is 3 mLs or 2.5 mLs. Tuberculin or TB syringe. This type of syringe is most frequently used for intradermal injections. of very small amounts of a substance. So remember, intradermal into the skin, just right under the top layer of skin. This syringe is also used for subcutaneous injections when only a small amount of medication, up to 1 ml, is ordered. And then insulin syringe. Insulin syringe is only used for injection of insulin, and you'll see that the markings on it are calibrated in units. The common size used today is U100, which 100 units of insulin is equal to 1 ml. Knowledge check. Which needle length is generally used for an intramuscular injection? A, 5/8, B, 1/2, C, 3/8, or D, 1.5? The answer is D, 1.5. The other lengths that are shorter are generally used for subcutaneous injections. Knowledge check. Which of the following is an intradermal injection? A, insulin, B, influenza vaccine, C, tuberculosis, D, vitamin B12. The answer is C, tuberculosis. Really what it is a tuberculin, which is a reagent that will react if somebody is positive for tuberculosis. Vial and ampule medication draw. There are 8 proper steps to drawing up medication from a vial. Step 1, wash your hands. You'll see that this is pretty much always the first step in anything related to healthcare. 2, assemble equipment: syringe, needle, alcohol wipes, and medication. 3, check the order using the 7 rights of medication administration and scan patient and medication in electronic medical administration (EMAR) system. 4, remove the vial's protective cap and wipe the rubber diaphragm with alcohol wipe. Check vial for date and any discoloration. So the rubber diaphragm, when you pop the cap off of a vial, there is a metal cap, and then it has a rubber piece in the middle, and you wipe that part down, and that's where you're going to push the needle through for drawing up the medication. 5, seat the needle securely on the syringe by pressing firmly downward on the top of the needle cover. Pull the needle cover straight off. 6, draw air into the syringe equal to the amount of solution you will be withdrawing from the vial. Insert the needle into the center of the rubber diaphragm and inject the air into the vial. Invert the vial, meaning flip it over, and then withdraw the prescribed dosage. Be sure there are no air bubbles present, and then withdraw the needle. So the reason that you push a little bit of air into the vial before you pull up is because otherwise with a glass vial, when you put the needle in, it blocks the hole that you punctured with, and it becomes almost like a vacuum. So putting a little bit of air in there gives a little bit of pressure for the liquid to then have some pull back into the syringe. 7, recap the needle carefully using only one hand to maintain sterility and to avoid an accidental needle stick. Hold the syringe in the dominant hand and carefully scoop up the cap without touching it. So you'll place the needle cap on the table and you put the tip of the needle into the cap without holding the cap, because you don't want to push the cap towards the needle and possibly poke yourself. Do not contaminate the needle by touching it to the outside of the cap. If using a safety needle, you can recap, then discard and replace the needle with a new sterile needle to use for injection. I do recommend drawing up with a safety needle, or sometimes we call them a blunt needle, because it does dull the needle tip a little bit when you push it through the rubber. And for me, I don't want to inject somebody with a needle tip that's already been slightly dulled. If the medication is in an ampule, hold the tip with an alcohol wipe to protect your fingers and break open along the scored marking at the neck. Tip the vial and withdraw the prescribed amount of medication and recap the needle carefully following the steps that were mentioned in step 7. So I will again post some pictures of this. An ampule is a little glass vial that you break open, and you have to use a little bit of gauze when you do it so that the glass doesn't cut you if it breaks a little bit or if it splinters a little bit. And then you're drawing up with what's called a filter needle. A filter needle makes sure that no little glass shards get into the medication. This is less common today than it used to be, but we do still sometimes get medications in ampules. And just hearing me talk about it probably doesn't give you a good picture. So again, I will post some images and or little videos into the Canvas shell for you to look at. Knowledge check. The following equipment should be prepped and completed prior to giving a patient an injection, except A, follow-up appointment, B, syringe, C, needle, D, medication. The answer is A, follow-up appointment. It was kind of a funny question because that's not exactly a piece of equipment. But yes, you will need a syringe, a needle, and the medication itself for an injection. Intradermal injection instructions. Proper steps to prepare and give an intradermal injection include 1. Wash hands. 2. Assemble equipment. 3. Check the order using the 7 rights of medication administration and draw up medication. If an EMR system is in place, scan the patient and medication. 4. Identify the patient and explain the procedure. The arm should be supported on a flat surface. 5. Put on gloves. 6. Cleanse the skin with an alcohol wipe on the inner surface of the forearm or other area if ordered by the physician. Allow the skin to dry thoroughly. Do not blow or fan the skin to assist drying because this can foster infection. Avoid areas with hair or blemishes. Hold the patient's arm in your non-dominant hand to make sure that you have a good grip on it while you're injecting, and stretch the skin taut, which means kind of spread the skin so that it's tight against the underlying structure of the arm because you don't want loose skin. It's a lot more uncomfortable for the patient. 8. Hold the syringe so that the bevel is up and the needle is almost flat against the patient's arm. Slowly insert the needle only far enough to cover the lumen or opening in the needle. The point of the needle should be visible through the skin. So this tells you just how shallow these intradermal injections are. 9. Inject the medication very slowly. You should see a small white bubble in the skin forming immediately. If no bubble forms, withdraw the needle slightly. It may be too deep. If the solution leaks out as you inject, the needle is not deep enough. 10. After the correct amount of medication is injected, withdraw the needle. Do not massage the area or you may interfere with test results. 11. Discard the syringe with needle uncapped into the sharps container immediately, without touching the needle. Remove gloves and wash hands. Note drug name, dosage, time, date, and site of injection on the patient's record. And then last, instruct the patient not to scrub, scratch, or rub the area. Provide written instructions regarding the time to return for reading. Tell the patient to contact the physician immediately or report to an emergency facility if they are experiencing breathing difficulty, hives, or a rash. If you see the picture on here, you can also see how shallow that is, but also the angle that they're doing it at is a very shallow angle, about 15 degrees. Which brings us to our next knowledge check. When giving an intradermal injection, the proper angle of the needle should be blank degrees. A, 5 to 10, B, 10 to 15, C, 15 to 20, D, 30 to 40. And the answer is B, 10 to 15. Proper steps for a subcutaneous injection. So I'm not going to repeat this with everyone, but the first steps will always be wash your hands, assemble your equipment, check the order with the 7 rights, identify the patient, explaining procedure. So that's going to be consistent for all medication. If the patient's getting injections frequently, we need to rotate the injection sites. So especially our patients who are getting subcutaneous insulin, they might be getting that 3 times a day with every meal. So we don't want to put it in the same spot every time. Typically for insulin, the best spot for absorption is on the abdomen, about 2 inches from the umbilicus, which is the belly button. So you just want to kind of rotate around within 2 inches around that area and not put it in the same spot every single time. For this one, after we put on gloves and clean the skin, we actually want to pinch the skin into a fat fold of at least 1 inch. So you want to get kind of a chunk of skin where you're holding the skin with a good amount of fat. It can be tricky if you have a very tiny patient who doesn't have a lot of body fat, but you do want to kind of pinch and get that little bit of fat there ready to inject. For this one, you will insert the needle at a 45 to 90 degree angle, and that depends on the amount of subcutaneous tissue available. So if a patient, again, is very thin, you'll need to go closer to 45 degrees. If they have more body fat, you can go at a 90 degree angle. You're going to inject the medication slowly, pushing the plunger all the way. You don't want to go too rapidly because an injection that's too rapid may cause pain. Now, your PowerPoint in your book here are going to say to place a dry 2x2 gauze over the entry site, applying pressure as you withdraw the needle. I do not recommend that, and I don't believe that that is currently recommended. I think this is a little bit outdated. You do want to apply pressure with gauze, but I wouldn't do it as you withdraw the needle because you run the risk of poking yourself with the needle, right? We don't want a needle stick injury. So typically what I do is I have my gauze ready and then I pull my needle out and immediately place pressure on the site. At that point, you will discard the syringe with the needle uncapped into the sharps container. Most of the time nowadays, the needles have these automatic kind of safety caps where you can just one-handed, you can push the cap up and over. But the reason this one is uncapped is because you are not going to have another hand at this time to cap it. So you need to just put it directly into the sharp container. You're going to remove your gloves and discard, wash your hands, note everything on the patient's record, and then observe the patient for effects. Knowledge check. When giving a subcutaneous injection, the proper angle of the needle should be blank degrees. A, 10 to 30, B, 30 to 40, C, 35 to 50, D, 45 to 90. And the answer is D, 45 to 90. When giving an intramuscular injection, there are 3 locations that the injection can be given. One is the ventral gluteal site. This site can be used for all patients, and the patient is positioned on their side or back. You can see in the picture below, the hand goes kind of on the hip bone. So the heel of the palm goes on the greater trochanter, which is where the hip bone meets the leg bone or the femur. And then you point your index finger toward the anterior superior iliac spine with your middle finger toward the iliac crest. Then you spread your index and middle fingers and form a triangle, and the injection site is in the middle of the triangle. Now, if that sounded like a lot to you, I agree, and I will tell you most nurses do not choose this site. Although the muscle itself is big, it's very particular with these sites that you have to line your fingers up with, and then it leaves kind of a small window for where you can actually place the needle. However, that being said, it is a very good spot. I would just say it's a little bit more particular than the other spots, so it's not a popular one amongst nurses or doctors who are giving injections. The next site is the deltoid site. This site is recommended for vaccines in adults and may be used in children between ages 1 and 18 for vaccinations. And for this one, you are going to feel for the acromion process and then the deltoid muscle, which is quite a large muscle. And you are going to kind of create a triangle with your 2 fingers pointing up towards that acromion process. And it's a nice beefy muscle on most people. And so this one is a much more popular one and one that you're more familiar with if you've gotten vaccines or you've seen vaccines being given. And not just vaccines can go in this spot. Pretty much most IMs, most intramusculars, except for you do have a ML limit because it's not as big of a muscle as the other 2. And so you do, if you have like a large amount of fluid, that's not a site that you're going to want to choose. The last site for injection is the vastus lateralis. This site is located on the anterior lateral thigh and used for vaccination of infants because those muscles are the most developed for children under 3 years of age. This is one that we use on adults as well. I usually use it if I have a slightly larger volume of fluid just because it's a larger muscle. And it can also be used on a patient who maybe is combative or is non-compliant with the medication because it's a better spot to get to than trying to place that on an arm if somebody is, thrashing, if somebody is at risk for injuring you or themselves. It's a nice big muscle to aim for. In terms of the other site that used to be given, because some of you may kind of be familiar with that, we used to give them kind of more in the back of the buttocks, and there runs a risk with that you could hit a nerve that runs through that site, and so it's no longer recommended. So these are the 3 that are currently being used. Knowledge check. Which injection site is mostly used for administration of vaccinations in an infant? A, Z-track, B, vastus lateralis, C, deltoid, or D, ventrogluteal? The answer is B, vastus lateralis. Proper technique for intramuscular injection. So again, same starting steps with all of the 7 rights. After measuring the correct amount of medication in the syringe this time, though, we're going to draw 0.2 mLs of air into the syringe, which clears the needle. Identify the patient, ask the patient's name, checking the armband, explaining the procedure, etc. We are going to put on our gloves, position the patient, clean the skin. With the non-dominant hand, stretch the skin taut at the injection site. Insert the needle at a 90-degree angle with a quick dart-like motion of your dominant hand. We will then inject the medication at a slow, even rate, withdrawing the needle rapidly after, holding a dry 2x2 gauze over the site. With these, we actually apply pressure and then massage the area gently with an alcohol wipe or gauze. This helps the medication to absorb. And then discharge the syringe with needle uncapped into the sharps container immediately. And then all of your same other steps, discarding gloves, noting everything on the patient record, and observing the patient for effects. Knowledge check. What is the proper amount of air to draw into a syringe to place in the vial for an intramuscular injection? A, 0.1 mLs, B, 0.2 mLs, C, 0.3 mLs, or D, 0.4 mLs? And the answer is B, 0.2 mLs. The reason for this with an intramuscular is because when you invert the needle back up to give the shot, that bubble goes to the back and it helps to make sure that every drop of the medication is pushed into the skin through the needle so that there is, when you push it all the way down, you can expel that last little bit of liquid out of the needle and into the muscle. Z-track injection. So Z-track injections are recommended for intramuscular injections that may cause irritation to the tissue. Some examples being iron dextrin, hydroxyzine, or cefazolin. Proper techniques for drawing and administering a Z-track injection are drawing up the medication, and then you're actually going to add a little bit more air this time, 0.3 to 0.5 mLs of air, and then replace the needle with a sterile one, 2 to 3 inches long. So you are going to make sure that you have a second needle to replace it with. Again, I'm going to do that anyway with my injections, using a blunt needle to draw up and then using a sharp needle as long as I have the supplies. Stretch the skin as far as you can to the outer side and hold it there. After cleansing the site, insert the needle with a dart-like motion and then inject the medication slowly, waiting 10 seconds before withdrawing the needle. When you do withdraw the needle and allow the skin to return to the normal position, this seals off the needle track. Press firmly on the injection site with gauze. Do not massage the site when doing Z-track because this could spread the medication to the subcutaneous tissue, causing more irritation. And then advise the patient that walking will aid absorption and to avoid tight-fitting garments that cause pressure on the site. There is an image here because I understand this might be a little bit hard to understand, but essentially it shows how when you retract the skin back to its normal spot, how it kind of closes off the needle track and causes less irritation. Knowledge check. What would be the purpose for administering a Z-track injection? A, patient preference, B, easily accessible site, C, offset medication that can irritate tissue, or D, less painful to patient. The answer is C, offset medication that can irritate tissue. IV administration and prescribed IV fluids. There are 2 types of IV administration. The first is continuous IV infusion, and the second is intermittent IV infusion via piggyback or bolus/push. So both IV administrations require similar equipment, which includes an IV catheter inserted in the vein and a bag of IV fluid, a small bag of medicine, which is called a piggyback, or medication in a syringe, which is given as a push medication. Generally, a physician, registered nurse, or licensed practical nurse is responsible for administering IV medication. It does vary from state to state on whether or not licensed practical nurses are able to give IV medication. Continuous IV infusion is administered slowly over long periods of time. The IV solution may or may not contain added medications prescribed by the physician. This medication is hung from an IV pole and typically infused via an infusion pump at a prescribed rate. So for example, pretty common order is 150 mLs per hour. There are 3 types of solutions based on the effect they have on the cell. Isotonic, cells remain the same. Hypotonic, cells swell, and hypertonic, cells shrink. It is important to know that for the most part, we are giving isotonic fluids such as normal saline. It's much less common to give hypotonic and hypertonic. As you can tell, because of the effect they have on cells, that can cause other problems to occur. Hypotonic and hypertonic are given under close observation if a patient has a significant electrolyte imbalance. Intermittent IV infusion is also known as piggyback. This is a term used for medication mixed in an additional bag that contains a small amount of IV fluid that's administered over a short period of time at a prescribed interval. An example of a piggyback would be like an antibiotic. For instance, Rocephin is one we commonly give. It's mixed into a 50 ml bag and it's given over 30 minutes to 60 minutes. So it is a small bag and it usually plugs into the large continuous infusion, which is why it's kind of known as a piggyback. It kind of gets plugged into the other one. It's piggybacking off of the other one. Most often, antibiotics are administered through an infusion pump, such as that ceftriaxone. An IV bolus or push is when a medication is not diluted in IV fluid but injected directly into the IV catheter. Some examples of IV pushes that we give frequently are IV Zofran, which is an antiemetic for nausea and vomiting, IV morphine. It's a small dose, a small amount of mLs, and it's pushed directly into the catheter itself. Knowledge check. Which is not an example of an IV solution that is utilized in a continuous IV infusion? A. Isotonic, B. Diatonic, C. Hypotonic, and D. Hypertonic. The answer is B. Diatonic. Local routes of IV administration. The IV route involves injecting liquids into the vein. The therapeutic effect of this route is immediate. The IV route is used for the following: administering medication, correcting body fluid imbalances, for example, dehydration. In that case, we're usually giving like a normal saline solution or a lactated ringer solution. Correcting electrolyte imbalances such as low potassium. Providing some nutritional support to patients who are NPO for a short time. Or administering blood and blood products. Knowledge check. Which is not a reason for a patient to receive an IV treatment? A. Excessive vomiting and dehydration. B. Administer medications. C. Prepare body for an athletic event. D. Body fluid imbalances. The answer is C. Prepare body for an athletic event, though I will say that there is boutique medicine these days where you can call and get an IV drip for, I want some extra electrolytes, or I want, B12. So that's very much boutique medicine, but that is not a common reason that we would be giving a patient an IV treatment. Self-assessment. What can you do to assist in memorizing the different forms of injection techniques? How will you practice preparing and administering the various types of injections? And as a healthcare professional, what can you do to ensure the safety of patients who may receive injections or IV treatment? This has been Chapter 9 of Essentials of Pharmacology for Health Professions. Thanks for listening.